There you go. So now this meeting is being recorded. You all are anonymous, so no one can see who you are. And if you have any questions, there's a chat box below on the right-hand side. We will have a Q&A discussion at the very end of Dr. Reyes' presentation. So if you have any questions, please put them in the box and we'll try our best to get through all of them in the time that we have. So without further ado, Russell will begin with Dr. C's bio.
So Dr. Francisco C. is a professor of public health and the chair of the Department of Environmental and Occupational Health in the School of Public Health at UNLV. At the National Institutes of Health, Dr. C was a senior program director and AIDS coordinator in the Division of Extramural Scientific Programs at the National Institute of Minority Health and Health Disparities. In his 12 years there, he served in various leadership positions, including the director of Office of Community-Based Participatory Research and Collaboration, and the Director of Office of Extramural Research Administration. He's the president of the NIH Asian Pacific American Organization as well. At the CDC, Dr. C was a senior health scientist in the Division of HIV/AIDS Prevention for 4 years. In 2003, he volunteered and led the CDC SARS community outreach team in Asian communities in the US to mitigate the fear and stigma associated with SARS. He was the founding president of the Association of Asian Pacific Islander Employees of CDC and the ATSDR. He taught and conducted research in infectious disease epi for 15 years at University of South Carolina School of Public Health, and Dr. C is the editor of AIDS Education and Prevention, an interdisciplinary journal, for 28 years. Dr. C earned his Doctor of Public Health in Immunology and Infectious Diseases from Johns Hopkins University, and his Master's of Science in Tropical Public Health from Harvard University, and his MD and BS degrees from the University of the Philippines. Also, and without further ado, here's Dr. C.
Good afternoon. Can you hear me? Okay.
Yes, we can.
Today, I'll talk about the epidemiology of COVID-19. So I'll be looking at, various aspects of transmission, coronavirus, diagnosis, treatment, and prevention. So, and then discuss how it affects different communities. So I'll be very general and try to be specific sometime. So the slideshow shows why does disease emerge. So in 1992, the Institute of Medicine, which is part of the National Academy of Science, formed a group, and they came up with 6 factors. If you see it on the left side in 1992, the 6 factors identified, and I highlighted those in red, which I think are responsible for the current pandemic: by microbial adaptation and change, human demographics and behavior and movement, international travel and commerce. All of these were responsible for, I think, the current pandemic. In 2003, another working group was convened, and they look at the additional factors for emergence. So these 6 factors still remain on the top, but in addition, they have climate change, changing ecosystem, poverty, social inequality, war, lack of political will, intent to harm were added as factors. But as you can see, the 3 emergent factors still remain the same: microbial adaptation and change, human demographics and behavior, population movement, international travel, all play a role in the emergence of the current pandemic. And this is a convergence model. In epidemiology, we learned that when agent and host interact in a certain environment, a disease can occur. But in this convergent model, you can see that the factors under the environment is broad. If you look at it to be, in the past, you just think of physical, environmental factors. But nowadays, you also look at genetic and biological factors, ecological factors, and very importantly now is the social, political, economic factors. All of this play a role that push the humans and the microbe together and cause disease to emerge and occur. So what's the coronavirus? Coronavirus are a very common source of upper respiratory tract infections and like a common cold. So, uh, but they're called coronavirus because they have crown-like spikes around their surface. So it's like corona in Spanish or Latin word. But there are four types of coronavirus: alpha, beta, gamma, and delta. But the one causing problem now is the beta coronavirus. And coronavirus are actually zoonotic infections. In other words, there are infections occurring in animals, which then could infect humans. But basically, they're going on in the animal population. So since mid-60s, then we have identified human coronavirus, and the beta coronavirus that have caused pandemics are SARS, SARS-CoV-1, which causes SARS in 2002 and 2003. And then MERS, which is Middle East Respiratory Syndrome, which started in 2012 and still going on. And then, of course, the COVID-19, which is caused by SARS-CoV-2, which started in December 2019 and continuing up to now. And that's our main focus now, is the SARS-CoV-2. As I said, there are 7 types of human coronaviruses, and 4 of them are the one causing common colds and problem now, and 3 of them we talk about causing pandemics. And so the SARS-CoV-2, the agent causing COVID-19, is a novel coronavirus. Novel means it's a new virus. None of us have been exposed to it. That's why all of us are susceptible to it. So initially we thought it's just air droplets. Now in the air droplets means when somebody cough or sneeze, it's found in the air and it will drop down. But now we realize that it's also airborne, meaning to say when it's in the air, it could be carried by the wind, and so it could go beyond 6 feet or 12 feet. So it's airborne transmission. And also when somebody cough and their hands are contaminated and they touch a surface, the virus could stay in the surface for a few hours or days, but they don't multiply or survive very long in the outside of the body. They don't multiply. So the more important is really the air droplets and airborne transmission. But since they can be found in contaminated surface, we have to use wash our hands with soap and water or use sanitizer. So this is how the virus look like. And you can see there's crown-like spikes around it. Those are S protein, and it's an RNA virus. You can see these are very important component when we do the diagnostic tests. From this electron micrograph, you can see the pink one are the viruses coming out of the kidney cells. They're replicating, and then they multiply inside the cell, and then they bud out of the cells, and they'll infect other kidney cells. So in other words, the COVID-19 doesn't affect only the lungs. It could affect multi-organs. Different organs will be affected. Now I want to compare SARS and COVID-19. So SARS pandemic, if you look on the left side first, the agent is SARS-CoV-1. The COVID-19 pandemic going on now is caused by SARS-CoV-2. And if you look at the host, the animal host for SARS started with bats, and then it's found in the bat population, and then intermediate hosts are cats called the civet cats. And then from the civet cats, it infects humans. For COVID-19, the reservoir hosts are the bats also, and the present belief is that probably the intermediate hosts are pangolins. And if you look at the origins for both of them, they came from China, the SARS from Guangdong, and COVID-19 from Wuhan. And SARS started in November 2002. It was contained in July 2003. And SARS occurred in 29 countries and about 8,000 cases, but the death rate is higher. 10% of those cases died. While COVID-19, you can see that started 2019, it's going on now for 8 months. It's spread to about 188 countries. And as of today, 41.4 million cases in the world with 1.1 million deaths. So about 2.7% of those cases died. Compared to, if you compare that with SARS, you can see SARS had 10% of them died, and while in COVID-19 it's 2.7%. And as we continue comparing the two, you can see that with SARS pandemic, most of the people who get SARS get acute infections. So within 24 to 38 hours, those exposed to SARS would show signs and symptoms. So there's no asymptomatic carrier with SARS. In other words, you can those with signs and symptoms like difficulty breathing, chest pain, and those you can identify right away with fever, muscle ache. All of those, all those infected show signs and symptoms within 24 to 38 hours. And then, so they're hospitalized, and then the transmission occur in the hospital setting. So there's no community spread. The other things about R naught, if you look at the left side under super spreader, the R naught of SARS, that means the reproductive rate of SARS is from one person, it can be transmitted to 2 to 4 people, right? And then the transmission for SARS is mostly in the hospital setting. You can see in 8 months, by July 2003, we're able to contain the pandemic. And how did we do it? Because it's mostly transmitted in the hospital setting. Infection control play a very important role. Of course, the PPE, testing, isolation, contact tracing, quarantine, all work together very well, and then we're able to contain it in 8 months. While if you look at on the right side, the COVID-19 pandemic, the difference that there's a high rate of asymptomatic infection, people infected, but no signs and symptoms, and we don't know who they are. And there you can see the R naught, the reproductive rate is about is less than SARS. You can see it's from 1 person to 2 to 2.5. Right nowadays, they probably could go as high as 1 person to about spreading to 5 people. So there's a high rate of super spreading with COVID-19. It's more infectious. And also the transmission with COVID-19 is mostly in the community setting, not in the hospital setting, because in the hospital setting, you use a PPE, so transmission there is less, but it's more going on in the community because of the asymptomatic carrier. And also the spread in contained facilities like nursing home, prisons, jails, etc. And the same thing is true, infection control practices using PPE. And because of the spread in so many countries, there was stay-home order. But the same thing is very important: testing, isolation, contact tracing, quarantine, social distancing, wearing masks. So this is the life cycle of SARS and MERS. If you look at on the left side, you can see the bats. The bats are the reservoir hosts. That's why it's very hard to control and eradicate coronavirus, because they're found in the bats population. And then you can see that on the top, on the left, you can see from the bats, it goes to the cats, the civet cats, which then infect humans. And then from humans, then you can see mostly it's a hospital patients. Hospital nosocomial means hospital-acquired infection. So we're able to control it using infection control practices. If you look at the bottom part, you can see the reservoir host against the bats, but then the intermediate host is the camels. So this is the one causing MERS. The Middle East Respiratory Syndrome is still going on right now. And then it affects the community. You can see that it's similar to SARS. It's also a nosocomial transmission, but it's still going on. Unlike SARS that has been contained, MERS is still going on in the Middle East. And it's spread to other countries because people working in the Middle East will go back and then cause infection in their countries. This is the pangolins. So pangolins actually is a a Malay word means pangulong. So in Tagalog, it sounds like parang gulong. Parang gulong means when they're threatened, these pangolins then would turn into like a ball, like a ball that will roll. So in Tagalog word, it means parang gulong, gumugulong. So it's a pangulong. So they're they are very important source of meat and scales, and their scales are supposed to have some healing power. That's why there's a lot of illegal uh, wildlife crime against these pangolins, and um, and nowadays we thought that there could be the intermediate host between um, causing the transmission of SARS-CoV virus too. Another thing to be worried about in the fall, aside from flu and COVID-19 in fall and winter, one thing that we're concerned about is the swine flu, which is called the G4. Right now, there's a swine flu G4 virus spreading among humans in China, and this is a new strain of H1N1. It's a swine flu virus, and it's found in pigs. So it's now going on in China, and hopefully it will not, spread around the world. But there's a concern that this might occur also this fall or winter. So we should watch out for this emerging disease. So SARS-CoV-2 is so easy to acquire and very easy to spread. That's why I call it easy come, easy go. 80% of those infected will have mild symptoms, and about 50% would show no symptoms at all. So these are the asymptomatic carrier. About 20% will develop severe disease and need to be hospitalized, and 5% of those hospitalized will have a life-threatening fatal outcomes. So this is the current situation in the world as of this morning. 41.3 million cases, 1.1 million deaths, and in the US, 8.3 million cases, 222,000 deaths. In China, where it started, they're able to contain it. It remained around 91,000 with 4,700 deaths. And actually, there are now 51 countries that have surpassed China's cases. In the Philippines, we have 363,888 cases with 6,783 deaths. But important to do is to look at the case fatality ratio per 100,000 population, so it's easier to compare the different countries. So if you use the case fatality ratio per 100,000 population, Peru actually have the highest rate, not the US. Peru is 124.32 per 100,000 population, followed by Belgium, 105.89 per 100,000 population. US is somewhere in the middle with 67.9 per 100,000 population. Philippines is 6.3 per 100,000 population. South Korea is 0.8 per 100,000 population. Singapore 0.5, China 0.3, and Taiwan has the lowest of all, 0.03 per 100,000 population. And we'll discuss them later how they did it in Taiwan. And this is the mortality rate in top 20 countries based on percentage. So you can see Mexico and Italy on top. Actually, this is an old slide. I need to update this. This August 27, and I thought I have updated the slides. And this is the R naught. You can see the average number of people that one person with virus can infect. So you can see for the flu, H1N1, one person can transmit it to 1.2 or 1.6 person. With SARS, one infected person can spread it to 2 to 4 people. With COVID-19, it's 2 to 2.5, although nowadays it's probably 2 to 5. Ebola is 1.6 to 2, and MERS is more, it's higher, it's 2.5 to 7.2. And then you heard so much about the super spreader and super spreading event. Actually, we recognize this early on, not just recently in the White House, but even before that. You can see in Singapore the super spreading event in the dormitory, or a music venue in Japan, or in the Zumba class in South Korea, or in a church choir here in the States, or in South Korea, for example, in May. There's a person who went to three nightclubs in South Korea, and they tested 3,000 people who were exposed to the individuals, and it actually causes, from one person, it spread to 170 new cases for one night for that one person. So there's a lot of super spreading events, and as I said, the more recent one in the US is the White House Rose Garden event. So we don't know yet what the biology of why some people become super spreaders. A lot of them are actually asymptomatic carriers. So if they're asymptomatic carrier and they don't wear masks, and you don't wear masks, and you're exposed in the crowded situation with them, then it's very easy for them to spread it and for you to acquire it. So these people who are super spreader have very high viral loads, and they shed a lot of viruses. And we don't know how they trigger it, but since we don't know much about it, it's better to be safe and wear masks because if you don't know your status, wear masks and make sure that you don't infect other people. So what do we do to prevent super spreading? We need to do testing and contact tracing. That's why it's very important to test. And if you're positive, then we contact the trace of contact of these positive cases and isolate those who test positive. And that's what they did in Taiwan. In Taiwan, they closed their border, and at the same time they would test, and those positive are isolated, and those who are, and they would trace all their contacts, and then those contact of a case are quarantined, but they're assured of their salary. Although Taiwan did not have a lockdown, they make sure the people have they were able to isolate and quarantine. So for epidemiologists suggest that the three C's: avoid closed spaces with poor ventilation, avoid crowded setting, avoid close contact with other people to prevent super spreading. So now we shift our topic to talk about COVID-19 tests. So there are two tests. You have the viral test and the serology test. The viral test, either oral swab, nasal swab, or saliva test. All of them are looking for active infection, and they're looking for the ideal test would be a PCR test, the polymerase chain reaction test, because it actually look for the presence of the virus RNA. So it's more sensitive. Then the other test that's called antigen test, they look for one of those protein that on the surface of the cell, the S protein. So those are looking for the antigen, and they can do this quickly in a few minutes, or they can get the results, but it's not sensitive. So to be sure, you need to confirm that using your PCR test, which is more sensitive, but you don't get the result right away. So those are the viral tests. And then serology, on the right side, you have the serology test that require a blood test. So they have to take blood from you to look to see if you've been exposed. Then if you've been exposed, then you can see antibody. So this is a test that to see if you've been exposed to the virus in the past. So they look for antibody. So this is gonna tell whether it's infection is going active or not. It just shows you have antibody developed against the virus. So if you look at exposure in the past, but if you want to look at the current status, active infection, you need to look at the viral test. And in the next slide, you can see the diagram here. So if you look from starting from the left side, even before the person shows signs and symptoms, you can see, you can look for the antigen, the blue line, this blue line here. You can see the antigen test here using the nasal swab, or the pink line using virus isolation from respiratory tract, or the pink line is the sputum test or the saliva test. So you can see that all of these are looking for the antigen. And so 1 or 2 weeks before the signs and symptoms, these viruses are being shed already, so you can detect them using the viral antigen test. And then you can see that they continue, but as the disease progresses, they will go down. So they're not very sensitive anymore. But if you look at the antibody test, these are the dotted line here. The IgM comes up first and then disappear. And then the IgG is the green one that will continue on. So to look at exposure, you can look at later on, you can see antibody detection. But for the early stages, you need to do the antigen test or the PCR test to diagnose active infection. And then the perfect storm is called the cytokine storm. Mean to say, when the virus enter your body, it causes immune response. So your body will try to attack. So you can see here, the COVID virus is entering your body to your nose or mouth. You can see the virus entering your body, going to your lungs initially. Then it can spread to other parts of your body. But because this is an antigen, a foreign antigen invading your body then will react to it and develop an immune response against it. So what happens is that there will be uncontrolled immune response to attack the invading organism. And you can see the immune cells are like the macrophage and the T lymphocytes. All of this will be activated, and all of them, including the dendritic cells, all these immune cells will try to attack this foreign antigen coming into your body. So the uncontrolled immune response mount against the virus causes this cytokine storm. So they will release a lot of, they'll secrete cytokines and chemokines. And all of this will cause more severe consequence, because that's when you can cause inflammation, a lot of reaction in the body. So one of the symptoms will be in children what's called the multisystem inflammatory syndrome, where you can see that the inflammation involves not only the lungs, but also the heart, kidney, brain, skin, eyes, and gastrointestinal organ. So this is rare, but this occurs in children. It can also occur in adults. So these are signs of the inflammatory syndrome. When they become severe, you can have difficulty breathing, confusion, bluish lips and face, and they should really be brought to the emergency room for treatment. So this is a report which will appear tomorrow. MMWR, the Morbidity, Mortality Weekly Report published by CDC. So they reported there's excess death associated with COVID-19 by age and race. They look at data from January 26 to October 3, 2020. So they found out that there's excess rate caused by COVID-19. At least 2 out of 3 of the excess death were from COVID-19. And the largest percentage increase were found among people, the Latino, who are in the age group 25 to 44. So if you notice nowadays, it's shifting, right? In the early part of the pandemic, older people are being affected, but nowadays you can see it's moving from younger population to the middle age population. For those who are hospitalized, you can see that the death rate is 6 times higher if you have underlying conditions. So hospitalization is higher by 6 times if you have underlying condition, and death rate is 12 times higher if you have underlying conditions. And these are the underlying conditions cardiovascular, diabetes, and chronic lung disease. So in the same MMWR report for tomorrow, when they look at race, ethnicity, and age trends in persons who died from COVID-19 in the US from May to August 2020, they found out that in the past, we know that people older than 65 and members of minority racial ethnic group have higher death rate. So in this report that they're going to issue tomorrow, they found when they look at this data from May to August 2020, they found that the death is 51.3% of death among the white, non-Hispanic, and then 24.2% among the Hispanic or the Latino population, 18.7% among blacks. So they found increased death rate from 16.3 to 26.4 for Hispanic. So this is the trend from May to August 31, the death you can see in May. So the black bar is white, non-Hispanic. The dark blue here are Latino. The light blue are blacks. And then this lighter blue is Asian. And then this one is the American Indian, Alaska Native, and Native Hawaiian. No, the Native Hawaiian is the white one here. And Native Hawaiian Pacific Islander. So you can see here that the increase is among the Latino. This is May, June, July, and August. And so, but you can see that still high for African American, remain high, and then the Asians here. And unfortunately, Filipino are lumped under Asian. That there's no very specific data for Filipino only. In some states like Nevada, Asian Pacific Islander are collapsed together. In other states like California, they have separate Asian and Pacific Islander. But it's still disproportionately high because the death is higher, and this population, based on their population rate, it's disproportionately higher, as shown later on. So from that study, we know that early in the pandemic, the death rate is highest among older adults. But in the May to August 2020 study of CDC, they found that the incidence among COVID-19 is getting high now in person aged 20 to 29. Younger people are getting exposed to it. We're talking about incidence here. And so you can see that as younger people get infected, they can expose then older people when they get home or visit their older parents or relative, they can expose them to the infection. So this is a report from APM Research Lab as of looking at data up to October 13, 2020, and they call it the color coronavirus COVID-19 death rate by race and ethnicity. So they look at aggregate data from all states, including District of Columbia. So they found out that 1 of 920 Black Americans have died of COVID-19. Or if you look at 100,000, it will be 108.4 deaths among Blacks per 100,000 population. Among indigenous American Indian, Alaska Native, it's also very high. It's 90 per 100,000 population. For Latino, 73.5 per 100,000 population. For Pacific Islander, it's high, 68.9 per 100,000 population. And for the white Caucasian population, it's 54.4. And for Asian Americans, 45.4. So when we look at the data in Nevada, southern Nevada, among the Asian Pacific Islander population, the death rate actually is higher than the Latino. Adjusting the data for age difference in race groups widen the gap in mortality between all groups in the white population. And so if you look at that, you can see that among blacks, actually the death rate is 3.2 times higher than the white. Latinos rate also 3.2 times higher. Indigenous and Native American Alaska Native is 3.1 higher than white, and Pacific Islanders 2.4 times higher than white, and Asian too is 1.2 times higher than the white population. So Filipinos are put under the Asian category. So we would have higher rate than the white population. And then you heard so much about herd immunity. So that's the immunity of the population to prevent transmission or control to pandemic. How how many of the population should have reached an immunity? So most of the time you get herd immunity by vaccination. So for example, in Ghana, to reach you need to have 94% of people should be immune to get to reach a threshold of herd immunity. For SARS epidemic in 2002, 2003, 60%. And for COVID-19, it's estimated about 50 to 55% population uh, it should be immune to it through a vaccination. At least 50% population should be immune to it to reach herd immunity. So the traditional way of reaching herd immunity is really through vaccination process, not through natural infection. Because if you want to reach it through natural infection, more people would have died. Millions of people would have died before you reach this herd immunity. So the impact on Filipino population, we don't have exact data. We have a lot of report from newspaper. Like for example, in this article in New Jersey, they talk about 1 in every 4 Filipino in New York, New Jersey are employed in the healthcare industry because uh, half of the nurses who are foreign born are Filipino and they're in the front line. But there's also a lot of Filipino who are caregiver working in the healthcare industry, so they're severely affected. So this is at the height of the pandemic in New York, New Jersey area. They report at least 30 workers have died. But if you look at the statistics, we don't have data by ethnicity, by Filipino ethnicity, so they lump together with Asian. But from this newspaper report, you can see at least in that part of New York, New Jersey area at that time, you can see a lot of deaths occur. The other problem with COVID-19 is increasing racism and discrimination and stigma against Asian Americans. And Filipinos are also affected because Filipino that look Chinese like me, they can think that you're causing COVID-19. So you can see um, they call you Kung flu, you call you Ebola, you call it Chinese virus. Uh, you know, get out of the country. So all of these are slurs, uh, virus-related slurs against Asian. And this is a study in March and April with Asian. You can see that they're exposed to anti-Asian discrimination about 70%. Shunning mean people shun away from you, about 22%. Some actually experience physical assault or being coughed spat on, or workplace discrimination, or barred from transportation. You call Uber and you have an Asian Chinese sounding name, the Uber may not even show up. And actually, the more recent data shows this is data uh, from July from Pew Research Center. You can see that discrimination, racism against by Asian and Black have increased also. You can see here, Asian and Black have are more likely than other groups to report negative experience because of their race and ethnicity. So it's not just Asian, it's also Black. Um, they're subjected to joke. This is the Asian. You heard the word Kung flu or Chinese virus. and people are afraid of them, fear someone might threaten physically attack them. So you can see it's higher among Asian. About 4 in 10 Americans say it's more common for people to express racist views about people who are Asian now than before COVID-19. It's more common now. You can see 39% for Asian. It's higher than any other minority group. Black and Asian Americans are most likely to report adverse experience due to their race since coronavirus outbreak began. Racism toward racial ethnic group also is more common now since COVID-19. So how about the impact of lockdown? So this study showed lockdown that occurred in different parts of our country and actually around the world too, showed that it prevent 500 million cases of virus from occurring. So that's important, very important finding. For example, in the US, 4.8 million confirmed. This is the estimated cases prevented by country. We're able to prevent 4.8 million cases in the US. In China, 37 million confirmed cases prevented. So all of these are very important in the lockdown, that it has important preventive measure. So in other words, there's no single magic bullet. People are always looking for a magic bullet, like a therapeutics or vaccine. Since there's no cure, no vaccine, there's really no magic bullet. But a combination of intervention work. Look at what happened in Taiwan. They only have 7 deaths out of 544 cases, or 1.3% cases. If you look at the 100,000 population, rate is 0.04. Vietnam, the same thing, 35 deaths, so 3.1% death rate. But then if you look at 100,000 population, 0.04. Singapore is 0.50. New Zealand, 0.51. They have 25 deaths among 1,914 cases. So what did we learn from Taiwan, Vietnam, Singapore, and New Zealand? What they did is they do a lot of testing, and then those positive were isolated, and then they trace their contacts, and their contacts were quarantined. And they also do a lot of infection control practices, hand washing, using hand sanitizer, wearing masks is very, very important, and also practicing social distances. So you can see that all of this in combination work very, very well, as shown by these different countries. So the updates about COVID-19 is that it's not only air droplet, it's airborne. So it can linger in the air, it can spread even beyond 6 feet. Face masks is very, very important. Cloth mask is very important in preventing transmission or being exposed to other people's viruses. So if we combine face mask, social distancing, hand hygiene, they're all very important in prevention control of coronavirus. And COVID-19 doesn't affect the lungs only. The lungs may be the first one affected, and you have difficulty breathing, but then spread throughout the body. And it's not just the older people get it, younger adults and children also getting it, and it's not seasonal. The fact that it's occurring in 188 countries, even in warm countries, you can see that. But you can see that this coming fall and winter, since it's colder, people tend to stay indoor. There'll be more crowded places and more exposure occurring. So you can see another surge in the winter time. COVID-19 is deadlier than the flu. That's true. More people die of COVID-19 than from flu. And as we can see, the virus is still being spread, cases increasing, so it won't just disappear. It will still continue to until we find a vaccine to prevent it. We need to continue wearing masks and practice social distancing. And the problem really is the 50% of people who are infected are asymptomatic and carrying it and passing to other people without knowing it. There's a lot of vaccine being studied now. A few of them have to stop because of the adverse reaction occurring in some of the participants. So I don't think we're going to have it this November. Probably it might be sometime next year. But there's a lot of studies going on right now, but still it will take some time to find a effective vaccine. So Dr. Fauci, there are 5 ways that he said can blunt the spread of pandemic resurgence. Wear masks consistently and correctly, avoid crowds, stay at least 6 feet apart, and if you a choice between indoor and outdoor activities, spend more time outdoor, and also wash your hands frequently. If not, use a sanitizer. So in the end, we're all in this together. Even though we cannot hold hands right now, but we need to practice each one, teach one. If we learn something new today, share with somebody you know. We must all work together to prevent, control COVID-19. For Filipino, we want to promote Bayanihan spirit of working together. And for Filipino, the Catholic religion, we need to keep our faith very strong. Or if you have other religion, the same thing is true. Keep your faith strong and believe that this too shall pass. I think that's my last slide. I think we'll have the Q&A later on, right? So we'll I'll start sharing my slide.
We're going to do the Q&A after Dr. Reyes' presentation. Thank you, Dr. C, for your presentation. We're going to go ahead and start with Dr. Reyes' presentation. First, I'm going to introduce him. So Dr. Andrew Thomas Reyes is an assistant professor at the UNLV School of Nursing. He joined the School of Nursing in 2016 and teaches both the undergraduate and graduate programs. His practice specialty is in the area of psychiatric and mental health nursing. His program of research focuses on the concept and construct of resilience among college student military veterans and Filipino American women with history of trauma and post-traumatic stress. He is currently exploring the effects of mindfulness on avoidant behaviors in post-traumatic stress disorder, or PTSD. He is also investigating on the cultural factors affecting resilience and trauma among Filipino American women. Prior to joining UNLV, he was a psychiatric mental health nurse for more than 25 years in several psychiatric hospitals in Canada. He completed his PhD in nursing at the University of Western Ontario in London, Canada, his Master's of Science in Nursing degree in Buffalo, New York, and his Bachelor of Science in Nursing in Tacloban City, Philippines. So here we are with Dr. Reyes' presentation.
Thank you very much, Noe. Can you hear me? Hello? Hello?
Yes, yes, we can hear you.
Yes.
Okay, great. Thank you very much. I just want to make sure because I'm using my phone. Something's wrong with my video camera. So thank you very much, Noe and Russell, for that wonderful introduction. And my presentation is titled Mental Health and Coping with COVID-19 Pandemic. So Russell, you can go to the next slide. So I first would like to acknowledge the Dr. C and the UNLV School of Public Health for giving me this opportunity to present in this webinar. I also would like to acknowledge the UNLV Wellness Zone, the Nevada Minority Health and Equity Coalition, the Asian Community Resource Center, and UP-MASA, which is the University of the Philippines Medical Alumni Society in America. So next slide, Russell, please. Thank you. So I just have a couple of learning objectives for today. One is to examine the prevalence of mental disorders related to COVID-19, particularly among Asian Americans, and to explore effective coping strategies with the mental health effects of COVID-19. Next slide. So first would like to introduce myself. I am an assistant professor at University of Nevada, Las Vegas, or UNLV School of Nursing, and I've been a psychiatric mental health nurse for over 25 years. And most of my practice as a psychiatric nurse was in Canada, mostly in Toronto, Ontario, Canada. And I've been here at UNLV since 2016, and my research program is focused on resilience in people with post-traumatic stress disorder. And I have two population cohorts that I am studying. One is the Asian American women, more particularly the Filipino American women, and the military veterans who've been discharged from service and who decided to go back to school. I have conducted many research studies in this area, and currently I'm working on cultural factors affecting resilience and trauma among Asian American women, more specifically Filipino American women. I'm conducting an ethnographic study. And then with the military veterans, college students, I have developed a mindfulness app intervention, tested that, and now we are in the process of further testing that through a randomized controlled trial study. So next slide, please. So I just want to first of all report to you some of our research, because my presentation today really, I don't really have a data on the Filipinos within the Southern Nevada area, and and I don't really have a lot of Filipino American data as well. But we conducted a research on resilience of Filipino American women here in Southern Nevada, and you know, Dr. Chad Cross, who is here in one of the audience here, is here, who was also one of my co-principal investigator as well in these studies. So we found that, you know, among Filipino American women here in Southern Nevada have high levels of resilience. We really think that we are, and this really resonates with all the messages we see in media about Filipinos as well. You know, I see a lot of travel YouTube videos, and a lot of foreigners, like from Australia, from Europe, from the United States, they go and live in the Philippines, and they make videos about the beaches in the Philippines. And one of the things you will hear about what they're talking about is that we Filipinos are resilient. And if you see some, you know, Filipino shows and drama shows, Filipino soap opera, and all that, so you know those shows, you could also see the theme, not only the importance of education, but also that we Filipinos are resilient. We also found in our study that there's a negative relationship between resilience and PTSD. What this really means today is that the higher level your resilience, the less severe your PTSD. And what we found also among our sample, that the more severe your PTSD, the lower level your resilience. We also found among Filipino American women here in Southern Nevada that the most common form of trauma exposure we have are non-interpersonal. So in the betrayal trauma theory, that theory says that, you know, when you have a personal source of trauma like sexual abuse, rape, you know, psychological abuse, especially from somebody close to your family, like a stepfather or something like that, there is more severity, it produces more severity of PTSD symptoms. But for most of us Filipinos, especially my sample here, is that the source of trauma exposure were really non-interpersonal, like calamities and accidents. But there were also a lot of our sample who were also victims of violence and abuse. And lastly, there was a high level of family norms against disclosure of mental illness. What this really means to say, we are very secretive when it comes to mental illness. We don't want other families to talk about, you know that we have somebody who has mental illness within our family. You know, although there is a lot of more acceptance of depression and anxiety, but we still are very secretive. And, you know, especially here in America, we have a smaller community of Filipinos, and we are fearful of ruining our reputation. Next slide, please. Okay, so it's really a serendipity that I am now focusing my research in COVID-19. This was not as many scientists are too. You know, they started to work on COVID-19. So what we did, we actually had developed a smartphone app intervention for college student veterans with PTSD. We published that, and a researcher from Europe saw our publications and then published also a commentary and said that, why don't you consider your smartphone app intervention, your mindfulness app intervention, to be applicable to those who are traumatized by the COVID-19. So next slide, please. So we published a response to that commentary that, yes, I think that's really a good idea, and that we will be considering and applying this, our smartphone app interventions to healthcare workers, more particular healthcare workers who have been traumatized by the COVID-19. So next slide, please. So then, what is the impact of COVID-19 pandemic on mental health? You know, the fear of contracting the virus, you know, the uncertainty about the course of the pandemic. You know, we don't know how long, just from the Dr. C's presentation, the virus is not going to go away. Oh, wow, that's, it's just our sense of hope is even just becoming more minimized. It becomes smaller. And, even the healthcare workers working every day, being traumatized, seeing all of these traumatic experiences right up to their face. And they're asking, when is this going to end? And then the unprecedented aftermath of extreme curbing measures, the lockdown measures. We Filipinos, we love to socialize. We love, and then we love to go to parties, and now we are withdrawn and isolated. And of course, wearing personal protective equipment, just like the nurses, wearing those, imagine wearing them for over 12 hours, for 16 hours at work, plus the stress that they're experiencing, that leaves us helpless, frustrated, and desperate. And these emotional states also are very strong trigger to developing anxiety disorders, mood disorders, and trauma-related disorders. So next slide, please. Okay, Dr. Zhang in Toronto and her colleagues in Toronto and in Singapore, they conducted a systematic review of all publications about mental health impact of COVID-19. And they found that, the most common mental disorders associated with COVID-19 are anxiety disorder, depression, and trauma-related stress disorder. An example is PTSD. Okay, PTSD is technically under anxiety disorder, under the umbrella of anxiety disorder, but they separated it for a reason, because anxiety disorder here are more symptoms of generalized anxiety disorder, like irritability, difficulties sleeping, concentration, but trauma-related disorder is quite distinct from the anxiety disorder when in the context of the COVID-19 pandemic. Next slide, please. In the next few slides, I just want to show to you the impact of the mental health impact of the COVID-19 within the American population and as well as the Asian Americans. We really did not have, I did not find any data on Filipino Americans. And as you saw, many of you here are also scientists in the Asian American population, and it's really hard to, they try to combine all of the Asian ethnicities. So Liu and her colleagues in Boston, they surveyed about 900 young adults. They found that about 40% of this population had high level of depression, 45% had anxiety disorder, and 32% had high severe PTSD symptoms. And so these are really large proportion. I'm not kidding you. These are really very big proportion of mental disorders. They found that also, looking at Asian Americans, that Asian Americans were less likely to report anxiety, depression, and PTSD than whites. And again, we can expect this, I guess, because Asian Americans, it's not only Filipinos, it's Asian Americans are very secretive. They're not very forthcoming of their mental health symptoms. Next slide, please. Dr. Lee and his colleagues as well in Virginia, they look at a coronavirus anxiety scale, a very specific anxiety scale, looking at anxiety symptoms related to the coronavirus. They found from the study that Blacks had significantly higher CAS scores than Asian Americans. However, they conducted another study about 2 weeks before this, almost double the size of what they have now, almost about 800 U.S. adults. And from that study, the same thing as well, exploring the coronavirus anxiety scale, that Asians had higher CAS scores than Blacks and whites. So if you could tell here that Asians are more forthcoming, we're seeing that the Asians are more forthcoming when it comes about fear and worry and anxiety about the coronavirus pandemic. Next slide, please. And then Litham and O as well, Dr. C talk about racial discriminated relation related to the COVID-19. They look at Chinese Americans. Well, I couldn't find any data on Filipino Americans. But Litham and O look at Chinese Americans who encountered COVID-19 related racial discrimination, and they found that among those groups, they have low levels of life satisfaction, very increased symptom, increased severity of depressive symptoms, and that also depression mediate the relationship between discrimination and life satisfaction, but ethnic identity moderated on the relationship between discrimination and depression. I know these are very technical terms, very statistical technical terms about mediation and moderation. What it all really means to say here is that among those Chinese Americans who've experienced racial discrimination related to the pandemic, they have very low life satisfaction, high level of depression, and that depression even make their life satisfaction even more worse. However, their sense of being Chinese, their ethnic identity, kind of have a buffering effect on their level of depression. Next slide, please. And then Dr. Edman and her colleagues in Boston as well, they look at compared two representative groups of U.S. adults, very large national population groups. They look at those in before COVID-19 and another group, those in during COVID-19. And they found that the prevalence of depression during COVID-19 was almost half of that sample. However, before COVID-19, the sample was only about, the depression was only about a quarter. Can you just imagine how you could see here that the pandemic is really impacting us, a larger prevalence of depression. And they look at Asian Americans. Again, during the COVID-19, about a quarter of the Asian Americans already had depression. But before COVID-19, only 4%. So that is a big jump, almost 18.7 percentage point higher difference between during COVID-19 and before COVID-19. Next slide, please. So, and then Dr. Cheisler and his colleagues in Boston, they also surveyed about 5,000 U.S. adults and about 4.7 were Asian Americans. And they found that among Asian Americans, 14% had anxiety disorder, 14% have depressive disorder, 22% have PTSD, 6.7% started or increased substance abuse like alcohol, and 6.6% had seriously considered suicide in the past 30 days. And I'm really more appalled with the last one, with the suicide. You would say that 6.6 is very low, but it is really high. Can you just imagine, because of COVID-19, about 6.6% of these Asian Americans within this sample have considered killing themselves within the last 30 days. So that is really serious. And then as usual, as we expect, Hispanics have higher anxiety, depression, trauma, substance use, and suicidal ideation than Asians. And Blacks had reported higher substance use and higher rates of suicidal ideation than Asians. Again, Asians are not really very forthcoming when it comes to symptoms of formal DSM-side diagnosis of anxiety disorder and depression and PTSD. Next slide, please. And then Dr. Fitzpatrick and his colleagues in Arkansas, they look at about 10,000 U.S. adults, national representative sample, and 5.5% were Asian Americans. And here they found that Asians were significantly more fearful and worried than their non-Asian counterparts. But there was no significant difference in the perception of threat of COVID-19 between Asians and non-Asians. And there was no significant difference in depression and anxiety disorder between Asians and non-Asians. Yes, we could see that Asians are very more forthcoming when it comes to they're afraid and they're worried about the COVID-19. But when it comes now to actual symptoms of mental disorders, there was no significant difference. Maybe there is really no significant difference, but a part of that too as well is that we are not very forthcoming about our reporting our symptoms. Next slide, please. And then Dr. Zhu and her colleagues in Pennsylvania, they collected data in 3 waves, and 6.48% were Asian Americans. This is just a very small percentage of Asian Americans. As usual, Asian Americans reported greater stress and depression at wave 3 compared to white Americans. And then Asian Americans reported greater anxiety at all 3 waves compared to white Americans. So let me just kind of summarize with all the slides that I showed to you about Asian American statistics here. So we can see that really it's impacting us. Even Asian Americans, the COVID-19 is really showing to us that it has an impact on our mental health. Asian Americans are starting to report, especially on the side of stress and fear and worry and anxiety about the pandemic, but we still have a lot of work we have to do in terms of really reporting symptoms of anxiety disorder, depression, and PTSD. Next slide, please. This one is not from a scientific publication. This was from Business Insider, and this is not. I've been trying to really look the actual source of this, but the only thing I could find it is from the Business Insider. And I really just want to show this to you. It's not really about mental health, but I'm really just appalled with this statistic. Because I am a nurse. Among the nurses, the U.S. nursing workforce in the entire country, 4% are Filipinos. However, the COVID-19 related deaths among among nurses, about 31.5% are Filipinos. That is a big jump. You know, the nurses only represent 4% among the U.S. nurses. But however, with COVID-19 deaths, about 31.5% are Filipinos. And many people have said, well, you know, a lot of speculation, you know, have been brought about this. Well, maybe because a lot of Filipinos have comorbid disorders, let's say, for example, diabetes, high cholesterol, blood pressure, and all that other cardiovascular related comorbidities. But I think it's really more because I'm saying us, there are not non-nurses in this audience as well. There are a lot of nurses, Filipino nurses who are in the front lines, you know, Filipino nurses compared, you could see a lot more white nurses who are in management, in education, but a lot more Filipino nurses are in the front lines. And this data also has a lot to be attributed from nurses in California, in the western part of the country. So, but what I just want to show to you here is that there is a big disparity of the COVID-19. Next slide, please. So the next thing that I want to just share to you are now how do we cope now with the we know for sure there is an impact on our mental health, serious mental disorder with the pandemic, with the COVID-19 pandemic. How do we cope now? We know there is a lot of in terms of our body, the physiology, the lungs, but there's also an impact on our mental health. So. I'd like you to, or maybe, this could also be addressed to you, to your clients, your patients as well. If you're a healthcare provider, to encourage your patients and your clients to notice changes in the following, especially in the top 6 bullets, in these 6 areas. Your sleep, if you're having insomnia or sleeping too much. Are there any changes in your appetite? Are there any changes in how you are present, emotionally present and mentally present in your interactions with other people, with your family, with your friends? Are you very distractible? Are you distracted? You can't concentrate? Is your energy level low? Are you more worried than usual? And do you notice that you have some new or increased behaviors, more particularly like obsessive compulsive behaviors? I know it is normal for us, for example, I'm speaking for myself. I've been washing hands more than usual. I would disinfect all the grocery items I bought from the grocery before I put them in the refrigerator. I would wear gloves when I put gas in my car and I'm in the gas station. But are you doing all this, cleaning of hands and sanitizing more than usual? Are you washing your hands every 3 seconds? Are you wearing gloves all day, even if you're home? And then the 4 bullets below the lower level of the slide are more for depression and PTSD. Do you feel more depressed? Do you have some loss of interest? And I know many of us are not able to go to the recreation that we have been doing before. Let's say we are not able to do our facial or massage as usual because we're afraid, or we're not always going to the movies and more, or going to the casino and stuff like that. But there are also activities that are not really impacted by those lockdown measures. Do you notice that you have loss of interest in them? And rumination. There are a lot of research studies that rumination, predict depressed mood. And rumination is really being preoccupied about different kinds of cognitive processes, and you're just stuck into those thinking. For example, you say, it is my fault that other people died. Have I just been more closely monitoring all those telemonitoring at the hospital when working as a nurse? That patient would have not died. Or, you're just preoccupied and saying that over and over again and thinking over and over again, have you noticed any of those? And lastly is intrusive images and memories. Are you confronted with a lot of traumatic images? You've seen some patients died right in front of your face. Like I'm going to give you an example. Last week we had the American Association for Men in Nursing virtual conference, and one of the things they did was a training on COVID-19, and they were showing a video about a woman who was on, from day 1 to day 14. From day 1, she was just wearing oxygen, and then then started being ventilated, and then she died on day 14. I just couldn't, I have to leave from that webinar because it was just a traumatic, those were just traumatic images for me. So are there any kind of traumatic images or memories that just kept on coming back, and all you have to do is just not think about it, you suppress it, you don't want to feel it, you want to just drink a little bit of wine, a little bit of vodka in order to numb yourself. So those are beginning signs and symptoms of PTSD, post-traumatic stress disorder. And next slide, please. So what do we do? How do we cope with the mental health impact of COVID-19? Number one is stay connected with people. There is research that social support really contributes to your resilience, especially with trauma and depression. And even if you just have to connect through Facebook, through Skype, through Zoom, through Instagram, through TikTok, and all of those, stay connected with people. And it's not for you, you don't want to, it's try to socialize your problems. It's not that you're trying to explore solutions with your friends, but it's really just more feeling more validated and acknowledge that, what you're going through is not unique to many people. And they said, they always said that misery loves company. Well, if it's about my misery, maybe I really need some company. So, it's about really being connected, socializing. It's not about exploring solutions there. Limit your access to news. We need information. Yes, I hear that we need information, especially that the election is coming. You need to know how many people are infected with COVID-19, but really just limit your access to news. Structure your time when you actually watch the news. If you're just gonna watch, get more information, just do it from one source, let's say from the TV, and don't go to your Facebook, to your news app, for example. Or, for example, for me, I just watch the news from NBC, national and local NBC News, but I don't go to CBS, ABC, CNN, ABS, CBN, GMA, TFC. So I don't do that. I just have to focus only, it's to limit your access to news because they really contribute. You don't really know the impact of watching those terrible news into your mental health. Actually, if there was in 2013, the Boston Marathon shooting, there was a study conducted from UC Irvine, from University of California in Irvine. They found that people who were actually just watching the broadcast from the Boston Marathon shooting in 2013 developed more PTSD symptoms than those who actually were in the actual Boston Marathon shooting. Remember, PTSD is not just a direct experience. You could also develop PTSD just from hearing from somebody about it. Okay, so limit your access to news. Maintain or establish a regular routine. So if having a regular routine gives you the sense of accomplishment. It lifts your mood. It lifts your spirits. So if you have a regular routine, already maintain it. Especially healthy eating. It's very tempting for us. When we're healthy, when we have some healthy eating routine, and we're getting stressed and we're getting traumatized, and we say, you know what, I need more 2 cups of rice. I deserve this. So I'll order more, 2 orders of Jollibee spaghetti or 2 orders of crispy pata in order for me because I deserve this. I'm really stressed right now. But if you don't also have a regular routine, try to establish one. Do 10 push-ups a day, walk in the park for 10 minutes, because having a regular routine gives you that sense of accomplishment. Then seek professional help. Be open, start opening up to your doctor. And many of us Asian Americans, especially Filipinos, we are not really very forthcoming to our mental health symptoms. And sometimes, I'm just lucky enough, my family doctor always asks me, do you have any anxiety symptoms? Sometimes some of family doctors won't ask you those symptoms. So be forthcoming to them, start opening up to them. And if you're not ready for any, let's say, you could say to your doctor, I'm not ready for any psychiatric medication. I'm having this difficulty of sleeping. I'm having this intrusive images that keeps on recurring to me. I'm just drinking alcohol to numb myself. But right now, I'm not ready for any antidepressant. Tell your doctor about it. And maybe, you could say, give me some, help me refer to a psychotherapist. So as family doctors, we are, we need to kind of really look at more collaborative relationship with our clients. As well, these are helplines that you can, if you are concerned about your privacy, then just call this helpline for now as a start. And lastly, practice mindfulness. In PTSD, for example, which is my research program, the more, when you have those intrusive images that keeps on recurring, what we try to do is that we try to suppress them. We don't want to feel them. We don't want to think about them. We try everything not to think about them. Research have shown that the more you try to suppress them, the more you try to avoid them, they have a paradoxical effect. They even make your traumatic symptoms even more worse. With mindfulness, it is simply observing them as thoughts are just thoughts, feelings are just feelings. One of our exercises in our smartphone app is that you imagine yourself sitting in the river, by the river, and then you see leaves floating by on the river. So you have it while you're meditating. You remember something. You put that thought in top of the leaf. Then another leaf floats by. Put that thought on top of the leaf. There are different kinds of mindfulness apps in your phone. And some of them are free. And you can also even go to YouTube videos and listen to some of the mindfulness meditations there. But again, mindfulness is not for everyone, but maybe, just consider if this is, explore if this is something for you. So, and the next slide, please. Yeah. So I guess that's really it for me. Thank you very much for listening. And I'm also open now for questions. Dr. C and I are open for questions.
During the presentation and during the registration, we received a lot more questions. I don't think we'll have enough time in the next 10 minutes to answer everything, but we'll try our best to ask the ones that we can, and then maybe afterwards we'll send like a written statement. We can go over the questions in more detail and send it to everybody.
Yeah. And then also, Russell, I've seen all those the questions as well, and I think I tried to incorporate some of the answers of some questions into my presentation today.
Okay, that sounds good. Why don't I just ask some of them, and then they can be directed to both of you, and then we can just keep going until time's up. The first question is, how can local family doctors and other frontline care workers assist the Filipino community during this pandemic?
Maybe I can answer that first. In terms of mental health, what I talked to you earlier about, that Asian Americans, Filipino Americans are not very forthcoming about their mental health symptoms. There is research as well that a lot of our mental health symptoms are manifested in physiological symptoms, in somatic symptoms. Who knows? Maybe the cancer and all those stuff, right, are really manifestation of mental health. We don't really want to go that late stage. What I'm trying to say is that for family doctors to really encourage, acknowledge your clients, your patients once they start talking about their mental health. And just acknowledge them and validate them and say, thank you very much for sharing that. Let me know how I can help you. And and also really looking at a context where your relationship with your patient should not be from expert and your patient are just passive recipients of whatever you're recommending to them. Because sometimes with Google now, with internet, our clients, our patients are more knowledgeable with their illness than us. So or than the family doctors and nurse practitioners. So, always listen to them first, what do they already know, and begin from there.
Right, thank you, Dr. Reyes. Dr. C, do you have anything to add?
No more questions.
The next one we have is, when reaching out to the Filipino community, what cultural consideration must be made or accounted for when discussing the possible impact of the COVID-19 vaccine?
I think we have to be honest and tell them that the current situation, that there's a lot of vaccines under clinical trials. It's a randomized clinical studies are being conducted, and so far there's no. It will take time because it will take at least 30,000 patients for the studies to be completed, and they have to also wait for a while to see any kind of adverse reaction from these patients. So people who are waiting for the vaccine are thinking there's a magic bullet based on our experience with a lot of other diseases. For example, we have AIDS that started in 1981. Up to now, we don't have vaccine for AIDS yet. So you can see that it might take time to find a vaccine. So in the meantime, while waiting for vaccine to be discovered, I think people should practice what we know that work. You can see those countries like Taiwan, Vietnam, New Zealand, and Singapore, South Korea have shown that the vaccine that they found is the vaccine of social response to it. Wearing masks, practicing social distancing, hand washing, all of this work together, and also testing, isolating, contact tracing, and quarantine, all this work together in preventing the spread of the virus. So be responsible and wear your mask every day, and treat everyone that you meet, stranger you meet, think of them as a possible carrier, and try to avoid avoid contact with people that you don't know. So that it's just, I think, be more practical about it, and wait until you find from credible sources. For example, if Dr. Fauci announced that NIH found a vaccine that's effective, and that Dr. Fauci is even going to use it, then you can be assured that he's a very credible scientist, so you could listen to him. But if you're hearing from somebody else and it's not credible, I don't think you should follow the advice. But make sure that your source is very credible.
Another question for you, Dr. C. Somebody asked, did you say the case fatality for Asians in Nevada was higher than for other racial groups?
No, it's higher in African American, but then the last time I looked at it, it's higher than Latino. So in other words, but it's combined Asian Pacific Islanders. So some of it might be due to Asian, but some of it could be also caused by the high rate among the Pacific Islanders. It's hard to tease out which is which. But the last time I looked at it, it's a bit higher among Asian Pacific Islanders compared to Latino. And I don't know whether it's due to high rate of diabetes or underlying conditions or not, but that's also true in some parts of California. So we need to take a closer look at that and see. And also the other issue is disproportionate higher rate, because our population is smaller compared to the Latino population, but then we have more cases of people dying from COVID-19 than Latino. So it's again, we need to take a look at the data and see and follow the trend over time.
The next question, I think this would be for Dr. Reyes. How have Filipino American college students been impacted in seeking mental health services during COVID?
Thank you for that question. I guess, I think, there are psychological services available in many schools and colleges and universities throughout the country. Let's say at UNLV, we have those as well. I think, is to really start with that as well. As Dr. C was saying, that the younger population now is more impacted with the COVID-19, and so as well, we could say that even with the mental health impact as well, so what I'm trying to say is that go first to what the services closest to you and ask for help there. So, but I have to emphasize that again, to always seek for professional help.
Okay, we're about to end soon, but I think I just want to ask one more question. And like I said, if we didn't get to your question, we'll try and respond to it later on in a written statement. There has been a lot of questions asking if this presentation is being recorded. Yes, it will be recorded, and we will be making it available later on, and we'll send the link to everyone who registered. I think the last question I'm going to ask both of you, and I think it's very appropriate, are what are the components of culturally competent care during the pandemic for Asian American Pacific Islanders?
Say the question again.
What are the components of culturally competent care during the pandemic for Asian American and Pacific Islanders? I guess how can providers be more culturally competent when working with the API community?
Okay. So for me, I'm going to start first. To me, it's all about what are the components of a culturally competent care provider. We always think, that ethnic matching is the best. That if I'm Filipino, I can care for a Filipino patient better, right? But there is really no evidence there that it's true. But what is really more important is that, are we more inclusive? Are we respectful of other people's values? Do we ask them first before we provide recommendations? So it has to start first from us as care providers, is to be always open and be sensitive to their values. That we all have different perspectives and we all think differently.
For me, to be cultural competent, I think we need to be a good listener. And when we talk to our community members, try to listen more, because you can hear wisdom coming from the community, and not make it one-sided that I know more because I have greater knowledge about this, but probably the community members might have more practical knowledge of what's going on in the community. And so it should be more like more listening and more practice what they call cultural humility, that we may know a lot of scientific facts, but we don't know much about the practical things going on in the community. But the community leaders and opinion leaders probably know more about, they can feel the pulse of community and they can bring the voice to you. It should be a give and take, sharing things. So I think in the evaluation survey, that's what we'd like to see when you get the Qualtrics survey at the end of the day. And I think we'd like to hear more about your views and also what's going on at the community level, because as you can see, we tried our best to get Filipino data and it's lacking. But one thing we'd like to do is even write a commentary paper that Russell, Noe, Dr. Reyes, and I are thinking about maybe putting a commentary paper based on our discussion today. So if we did answer questions and you see a question one, send an email to Russell and then he'll share it with us so that we can highlight and we respond to your question as best as we could. And also we can highlight the theme that we discussed in this seminar. And also if you have personal experience on how you're affected by the pandemic, feel free to share it with us, because this will be aggregated report together and we won't be naming names, and it will represent the voice of Southern Nevada, and we can add it to the literature. At least it could be descriptive in nature, as a commentary, because as I said, there's data's lacking. If there's data, we always lump together as Asian Pacific Islander, but hopefully we'll have to do more research in this area and then be able to do publish some data and share it, because we have, as Dr. has presented in that Business Insider report, there's high rate of mortality among the Filipino nurses who are in the front line. But imagine a lot of Filipino caregiver who are working in nursing home. They're also affected. They're not doctors, they're not nurses. They are the one providing care, day-to-day care to the elderly. So they're also affected, but they're not reported. So I think we need to explore this further and do some more studies and then And then next time we can have a real data that we can share with you.
Right, I think that will conclude our webinar, and we, on behalf of Russell, Dr. Reyes, and Dr. C, would like to thank everyone for participating. Again, there's going to be an evaluation survey that's going to be sent to you all. And again, send your questions to Russell so he can give it to Dr. C and Dr. Reyes for additional feedback. Again, we appreciate your time, and thank you.
Thank you.
Thank you, everybody.
Dr. Reyes, can we have a post briefing with Dr. Reyes?
Yes.
And Noe and Russell?
Yeah, Russell, can you see if the participants logged off?
We still have many participants, Dr. C. Should we do it in a separate meeting?
Oh yeah, probably, yeah. We have, after this, when you end the call, probably have another
Okay.
meeting. Okay, thank you.
Thank you.
All right,
Bye-bye.
see you guys in a few.
Bye.
Bye, everybody.